Okay, so we're just started to broadcast this webinar that's hosted by Nuffield Council on Bioethics. I'm just going to pause a moment because I'm just watching that the attendees are loading up here. I just want to make sure that we've got everybody before we get going. The number registered is something in the order of close to 900, and so I'm just making sure that we've got everybody in attendance. So thank you everybody, in particular our panelists, for joining us at this time, at different times in different parts of the world, but also at a difficult time for everybody in one way or another. I should just say that I'll be inviting our panelists to speak, and then we'll go to questions and answers. Those who are attending as attendees, we've not opened the chat function. It's a bit difficult to manage with so many people, but if you have questions at any point, you can post them in the under the Q&A button at the bottom. We'll get to whatever we can, but again, we may have to be selective as depending on the numbers that we get. We're going to record this so that we can also show it on our website afterwards and write a written note and maybe picking up some of the other questions. So we're hosting it, the Nuffield Council on Bioethics. We're a UK-based independent organisation looking at ethical issues arising in developments in biological and medical research. We published recently on research in global health emergencies. And what we're doing at the moment, in recognition of the urgency of issues around COVID-19, is convening a series of these online seminars where we can address a number of different issues that arise in this particular context. The first one today is around how research can be undertaken ethically during the emergency response to COVID-19. The nature of an emergency is such that it's outside of the ordinary. It disrupts a lot of normal patterns. It can create uncertainty and distress. The question is, how do we still enable ourselves to conduct research, essential research, ethically at that time, balancing clinical safety with the need for rapid vaccine and therapy development, genuinely informed consent from participants, facilitating effective collaborations between different areas and institutions, fair sharing and fair access, etc. These are a number of questions that become potentially more difficult in emergency situations. So I'm not going to say much more. I will get out of the way, and I'm going to invite each of our speakers in turn to speak to one particular aspect of this. If you can just introduce yourselves briefly. You can see the biographies on the website. So I'm going to turn first to Beatriz da Costa Thomé from Brazil. Beatriz, please go ahead, and you are in full view.
Thanks, Hugh, and thanks for this invite to participate in such an important endeavor in this such difficult time. So hello everyone, I'm Beatriz Thomé. I'm a physician by training. I'm based in Brazil at the Preventive Medicine Department of the Federal University of São Paulo. I was a member of the working group that produced the report that Hugh just mentioned on research ethics in global health emergencies. And I currently co-chair the WHO working group on ethics and COVID. So a few things. I guess I first would like to make a case, if we're going to start talking about research ethics, especially in emergencies, I want to make a case on a broader understanding of research ethics. So research ethics might be seen as the process of reviewing a research protocol that needs to go through a research ethics, and the way we want to frame a research ethics is much wider. It's to really think about the behavior of everyone involved in research, from funders to governments to research ethics committees, researchers. So it speaks to the relationships between researchers and research participants. It speaks on fair collaboration between institutions, involvement of community. So this is the way we want to shape research ethics. And also to say that research ethics should not be seen as a barrier to conduct research. So again, it should be a framework to support people in such a vulnerable situation, both from the frontline staff and researchers endpoint, but as well from research participants. So the Nuffield report, and I want to share a few of the findings of the report. I think one of its richness was that it was built on evidence that was gathered around the world, really, from various stakeholders, again, from funders to people that were participating in research, researchers themselves. So there are a few issues that we came across quite early in this process. So the first question that we had to answer was that, is it really a good time to conduct research when we're facing a global health emergency, right? So he was just saying a time of distress, disruption, and the answer came out quite strongly. Yes, we should be conducting research because it really informs what we're doing and what we want to see accomplished after the research. So regarding therapeutic vaccines, and not only that, and to see how people are handling all this on the ground. So yes, and we've seen with COVID, bringing it to our COVID situation right now, we've seen how quickly research informed us on the virus genomics, on the clinical presentation within a couple of weeks, and we are already going through a couple of clinical trials that we'll hear more soon. So yes, we should conduct research. And then the second question was, so then should ethical standards be loosened up a bit, because it is a situation in which we have to give quick response? And then the answer came out quite strongly as well, that no, we should not loosen our ethics standards, and maybe quite on the contrary, because research participants might be in a very vulnerable position that, and specifically for COVID, when there's no treatment options, for example, there can be a situation that, well, I'll take what people will offer me. So we really made a case about maintaining ethical standards, but of course, with room to adapt ethical review processes and research methodologies according to the context, but research remains a key aspect of response. So the Nuffield report does put together, in order to support people on the field, an ethical compass, which three universal ethical values that should help decision making. So one of them is eco-respect. So really speaks about treating research participants with respect, and speaks about community engagement. So how are communities engaged even in a rapid way? How are these voices being heard? Are we addressing the right research questions? The second value being fairness. So I guess it's easy to imagine how situations that fairness could be left behind, for example, in the sense that we need to collaborate, and in these public health emergencies, there's a lot of international collaborations. And so how do you make these collaborations fair between external researchers, local researchers? And the third value would be to reduce suffering. So throughout the research cycle, how do we balance what we're doing in order to be sure that we're trying to address the right research questions that will bring answers to the communities? So it speaks about priority setting and who helps, which voices are heard in order to set these priorities. So I guess the Nuffield report is a real resource for the time of COVID-19. And I also wanted to say a few words about what WHO is also doing. So WHO early on convened a group of experts in all thematic areas, thinking about how research could help the response for this new coronavirus. And a group on ethics was formed. And one of the first things that this group came across was that there was already a lot of robust guidance on how to conduct research ethically, and also during emergency. So we have the Nuffield report, the WHO guidance after post-Ebola on ethics during outbreaks, and it also includes considerations for research. So the challenge was really how to translate this authoritative guidance that was already in place into practice, and how to provide tools and real support on a day-to-day for people on the ground. So our way to work has been not only to embed ourselves in all the other thematic areas. So no matter if you're discussing vaccines, therapeutics, infection prevention control, we would like to see represented and provide support. So throughout the research thematic areas for COVID, we produced a couple of rapid guidance. So we turned all these guidance documents that exist into a 4-pager to start with on research ethics during emergencies. So there we highlight the importance of meaningful consent processes. So again, thinking about people at times when people will be vulnerable, how to, under an emergency situation, how to still keep transparent and meaningful consent processes going, how to engage communities in the decision making. And WHO is trying to give some practical guidance as well. So something else that we worked on that should be up on the WHO website soon is rapid guidance for research ethics committees. So of course it's not business as usual. People are not even meeting in person anymore. So how can research ethics committees adapt to the situation and conduct still robust ethical review, but in different ways? So virtually having ad hoc committees. So this is some guidance that is coming out as well. And also about not duplicating efforts. So probably if there's an international collaboration, if you have an international ethics review committee approving a research protocol and then having a local research committee approving a protocol, that's probably enough. We shouldn't be duplicating research efforts, and also trying to have strategies such as what the WHO came across, which was to create a master protocol that then gets approved by WHO that makes it easier for other research ethics committees to approve a given protocol. Some of these practical issues to be thought of. I guess I'm going to end now, but just to give a final thought that all these, have been thought of. There's a lot of literature on pandemic preparedness, and here we are facing a very difficult pandemic. So I'm going to end with the thought on for us to really make an effort to build some collective memory on this, and then lessons learned and what helped us and what did not help, thinking about ethics and how to build capacity moving forward for help us and prepare for the next one. So I'm going to end here. Thanks, Hugh.
Thanks very much, Beatriz. Now, I think that last word about, of course, we've got immediate and urgent concerns, but the question about preparedness is going to be so important, and learning from this, because this will come again. Jeff, I'm going to hand over to you now, and thinking about it in kind of getting to the practical end of things. How do we balance those concerns about safety, the need to develop rapidly vaccines and therapies, and how we get them out in an equitable fashion? Jeff Kahn.
Thanks, Hugh. Let me say thank you for inviting me, and thanks to Beatriz and Susan for joining me on this panel. I'm at Johns Hopkins University, where I'm director of the Berman Institute of Bioethics. That's in Baltimore, Maryland. So good morning to you from beautiful Baltimore. You'll see the light coming up behind me as the morning dawns. I'm going to talk a little bit about a more specific kind of example, and it will be a nice segue from Beatriz comments about things like loosening restrictions. So as I'm sure everybody on the webinar knows, there's a scramble to try to figure out whether there are potential therapeutics, and in particular there are vaccines that might be developed in response to the COVID outbreak. And here in the US, we have one trial that has just started. And just to sort of put a little bit of framing around this, and typically it takes 18 months or more to develop a vaccine, sometimes as much as 36 months. And of course, we're in the midst of a a pandemic, and that seemed like an eternity from now, considering what our lives were like merely 2 weeks ago. 36 months from now seems like, well, gosh, that's just not fast enough. But there are reasons that it takes that long. And so urgency and speed are kind of the enemies of safety and mitigation of risk when we talk about developing things like new vaccines. And the reasons that we take that long tend to be mostly focused on the kinds of things that I think Beatriz was referring to in terms of how we know when it's safe to go into human subjects for the first time. So typically animal models are used, sometimes multiple animal models are used early on in research to determine first safety, and then whether you're getting the kind of response in a living organism that you hope will also be the case in humans. And that's why it takes a longer time, first to get into humans and then to test in humans until you're ready to produce something. We're skipping some of those early steps, at least in the first trials here in the US, as a way of trying to get data more rapidly. So I think there's an open question about whether that constitutes loosening of ethics restrictions. So that would be a sort of question to raise. Why do we worry about that? So there's really two reasons. One is a commercial one. It doesn't make sense to spend the money that it takes to go into a human trial if you don't have good reason to believe that there's data from some other non-human model that it's time to go into humans and may lead to something you can actually market and sell. So that's a kind of commercial incentive. The other is the ethics and protection of human subjects question. So when we do vaccine trials, in particular prophylactic vaccine trials, so trials that we're trying to work on that we can use in healthy people to prevent them from becoming infected, that requires healthy volunteers. And in the context of clinical research, there are sort of two types: those trials that recruit and use in research healthy people, and those that recruit and enroll in research people who are sick, affected by the things that we're trying to work on. So in a healthy subject trial, we think much harder about the risks being posed, because an otherwise healthy person undertaking risk, certainly at the early stage, not for benefit to themselves, but for benefit to society and those who will come after them. So we have to be quite sure that the risk is appropriate, risk of harm. So it's really about safety. Early phase trials in humans are focused on safety and toxicity. Do they harm the person, and have very little to do with actually assessing benefit. That comes later. So that process is being sped up. Again, in the US, where the first few months of subjects and trials will be in a low dose toxicity only trial. And then if it's shown to be safe, the doses will be increased to see whether there might be some efficacy, some potential benefit to the subjects and eventually to people if the vaccine makes it through to market. So we want to be very careful about compressing the time frame in the interest of urgency, because we don't want to trade off risk to human subjects in a way that would loosen ethics in the way that Beatriz outlined for us. The second thing I want to say about vaccine trials in particular is this notion of who would participate. And of course, if it's healthy subjects, what would their motivation be? That starts to get into conversations about informed consent, which Susan will talk about, so I won't say much more than we need to understand, people need to understand what is being offered to them, especially in these very early phase trials where we're asking them to put themselves in harm's way, so that we can learn something about the safety of a particular vaccine candidate, and hope that we can move to a later phase where there may be efficacy and eventually, as I said, a produced vaccine. But people need to understand that, and their motivation needs to reflect that understanding. You also need to have exposure to those individuals if they have been vaccinated with a candidate vaccine. How do you do that? Well, one way is to literally challenge them, introduce the infectious agent to them. So you can think about that in the context of, say, malaria, where literally the plasmodium is injected into the individual. You see whether the vaccine has protected them, and if not, then you rescue them with drugs. Can't do that in a respiratory virus where there is no therapy available. So we probably, in this case, would be expecting them to be exposed through their normal activities of life. And so there's an ethical issue about how you would expose people who were vaccinated, and what would you do for them if they do become infected and start to show symptoms. So I'm going to skip over the consent piece because I know that's coming next and focus for the last couple minutes I have on what would happen once we actually have a candidate vaccine, and this really applies to therapies, about allocation. Who should get them first? And so when we talk about emergency contexts and limited supply, it's all about scarcity in those contexts, we think about prioritization and who should receive things and in what order. And so in the context of emergency response and emergency preparedness, we talk a lot about first responders first, because those are the people who are coming to the aid of all of us, emergency ambulance drivers, police, fire, public safety, and then the frontline healthcare workers that would care for those who are sick. So they would be first in line. Second are those who are at highest risk for the infection. And so COVID has a particular demographic in terms of the way it affects, seemingly affects the oldest old in much more severe ways than it does the youngest young, although maybe babies are at risk as well. And so we would want to vaccinate the most at-risk population first, then the way we generally have set it up, critical essential workers, so people who are making sure that we have groceries in our grocery stores, that the infrastructure continues to work, that we have electricity coming to our homes, et cetera. And then after those three categories have been served, everyone else. And so there's a sort of strict kind of sense of how we allocate when it comes to availability of something that is going to be likely scarce at the outset. It may be very expensive at the outset. I guess the last thing I would say is the sort of proposed therapeutic cocktails that include some of the anti-malarials are being tested, and I use that term guardedly, in hospitals in New York City in uncontrolled trials, but they're being used experimentally to see whether they might have some effect on at least symptoms, if not reducing the infection altogether. The problem with that, of course, is an uncontrolled trial, and it's not clear at all that there will be useful data. So there's, I think, an open question about how to do therapeutic research in the context of a pandemic outbreak when you're probably not going to be in a position of doing really strong controls. All right, that was a bit of a fire hose, and I apologize for that. Lots of caffeine this early in the morning for me, and it's probably showing, but let me say thanks and turn it over to Susan.
Thank you very much, Jeff. I now want to continue the discussion by talking about some of the ethical aspects, particularly related to planning and conducting clinical research in the coronavirus pandemic. And first of all, following on a little from Jeff's presentation, I wanted to talk about informed consent and the particular issues. And I think this divides up in some respects into talking about two very different populations when you're looking on the one hand at investigating a prophylactic vaccine, so a vaccine to prevent coronavirus, and on the other hand looking at a therapeutic to treat coronavirus, which in many cases you will be targeting a population that's very sick, very likely to be at least confused or even unconscious and ventilated. So on the other hand, as Jeff said, in vaccine studies, preventive vaccine studies, it is usual to target healthy volunteers, at least for the initial studies, even if eventually you'll be targeting some of the vulnerable populations that Jeff was talking about, you know, maybe the elderly, pregnant, or health workers. So in this situation, as Jeff mentioned, it's very, very important to give them a full information about the risks and the potential benefits of the study that they're considering taking part in. And as Jeff mentioned, in this situation of a pandemic, there is an urgency to develop a prophylactic vaccine. And therefore, as he mentioned, there are some situations where it may be justified not to do quite as much preclinical testing, that's testing in animals before going to humans. And I think that needs to be clearly explained in the information document so that the volunteers understand that. But on the other hand, it's also very important that they understand that they will not necessarily be prevented against infection from coronavirus after taking part in the study. Now, as I'll talk about in a second, this is partly because these studies tend to be studies against placebo, so that's a dummy vaccine. So, of course, if they were allocated to get the dummy vaccine, they wouldn't have any protection. But not only that, the investigational vaccine, we don't know whether that will protect them against coronavirus. So they need to understand that the potential benefit isn't for themselves, it is for the population on a broader. So that, they're doing this study in order to hopefully benefit the evidence that there is for a preventative vaccine. So that's very important. They understand that, because we need them to freely give their consent. Another aspect that was touched on by Jeff is compensation. That it's very important that any compensation to the healthy volunteers is not to a level where it could be construed as an inducement to take part in the study. So that is also mentioned in the information that would be given to the subjects. And it also would be clearly explained about the comparator, that it is a placebo. So moving on to the design of a study, as there is no effective coronavirus vaccine to prevent the disease, then the scientific, the best science would say that we should compare against placebo. Now, generally the volunteers that would take part would be 18 to 55-year-old adults, for example. Now, on the evidence we have at the moment, it appears that group of patients aren't at as great a risk as the elderly, for example, of getting severe coronavirus disease or dying of coronavirus. So I think you could reasonably argue that it's ethical to compare against a placebo vaccine. On the other hand, if the situation changes, or if it wasn't thought to be ethical to do that, another alternative would be, as was done in the Ebola vaccine development. One of the studies there compared immediate vaccination against delayed vaccination, because obviously Ebola was there was a higher mortality, so it wasn't felt ethical to compare against placebo. So that's some of the issues related to healthy volunteer studies. Moving on to therapeutics. As I've mentioned, this is a very different population in most cases, where they would be at risk of getting the severe respiratory problems, or have already got those severe respiratory problems that we see in coronavirus infection. So with these patients, it may not be possible to take informed consent from the patient themselves, as you can imagine. So therefore, you would need to consider discussing with the ethics committee and getting approval to have what we call deferred consent. So that would be where you would put the patient into the clinical trial and then take consent, hopefully at a later stage when they recover or improve their condition. Alternatively, or as well as that, you could also consider taking consent from a legal guardian or relative, if that's possible. But it's still extremely important that they're given the full information, because as Jeff mentioned, in this situation, the patient, the relative is going to be quite in a desperate situation and desperate for any possible treatment. And they need to understand that, of course, this is an investigational medicine. There may be risks that we're not aware of. So there are, on the one hand, some risks. On the other hand, the benefit is also not guaranteed. The treatment is being looked at to see if it's effective. And of course, there's this other issue about placebo, or what do you compare to? We should be doing clinical trials with, as well as Beatriz said, with no relaxation of the ethical standards, but equally no relaxation of the scientific standards. And we really need to be able to compare against placebo, because we don't have an effective treatment. Now, this would be more tricky perhaps to explain to relatives or a patient with a very severe disease, but it is the best practice, and they need to therefore understand that they might not even get the investigational drug, and even if they do, it may not necessarily help them. So that's a very important discussion to have with the the patient. So I think you see that there's a lot of issues to consider. Obviously, the situation for therapeutics may change as we get some effective therapies, and we want to continue to do clinical trials to get further, maybe more effective therapies. We may need to adapt the design, and in fact, there's a collaborative study set up by the WHO that is an adaptive design that is comparing against placebo, and will sequentially look at different therapeutics that might help in this infection. So what I wanted to just emphasize at the end is this importance not to relax the scientific standards. So for example, the inclusion-exclusion criteria should be kept to, which again is a difficult one. Sometimes the patient will be desperate to try and get any potential treatment, but we should be strict about the inclusion-exclusion criteria as we are for any study, keep to the ethical standards that we would always have, and hopefully with all the stakeholders collaborating, as we're seeing, the scientists, the clinicians, industry, the regulators, will soon have an effective therapeutic for coronavirus infection, and also be hopefully seeing a prophylactic vaccine in the not too distant future. So thank you.
Thanks very much, Sue. It strikes me that many of the questions that we address in the context of this emergency are questions that we do face in ethics in relation to research generally, but those questions of timing, questions of urgency, the anxiety, the disruption of normal patterns do make it means we face different questions in different ways, and they present enormous difficulties. I'm going to pick up some of the questions now that have been raised. I'll just say that we've got 10 minutes or so to do this. At the end of that, I'm going to invite those who have attended to fill in a short poll, just to help inform us as we do more of these seminars in the coming weeks, to help make sure that we get it as good as we can. But I just want to pick up some of the questions that have been brought in. I won't be able to do all of them. There's one interesting question, for example, about the extent to which universities as public institutions, how do they address questions about promoting access when we've got intellectual property issues? Should people be giving up the kind of intellectual property rights that they might have at a time like this? Does any of you, I'm going to unmute everybody here, all of you here, so if you want to come in. I mean, if you're working with others in your university, are people looking to make this fully public access?
I think it is the plea in general, right? So I guess for intellectual property, I think people are discussing how to, let go of some of these requirements. Or there has been discussion between private and public settings, for example, like we've seen Spain do, that the state took over the private hospitals in order to have more beds for the patients. So I think, it is a completely unusual situation. There's a lot of disruption. People should come up with alternative solutions and be creative, and everyone's going to lose a little. So we have to just try to be equitable about how much all of us lose.
Well, pardon me. One thing I would say about that is there are existing consortia like Sepi, which is set up really to try to blunt this problem and make vaccines, particularly for neglected diseases, available worldwide. And the funding comes from large philanthropies like the Gates Foundation, Wellcome Trust, and the UK government of Norway, to try to, I think, avoid this problem. I guess we'll see. This is the first time that it really has been invoked in a worldwide pandemic way. And so there are models, I think, that are trying to predict that problem and work to avoid it. We're unfortunately living through the experiment about how it will work.
Do you think that, I mean, it's interesting how not only has COVID-19 kind of become global in a way that you know, even in SARS and previous ones, the scale and the rapidity is probably of a different order, but so has been the response. Can we hope at the least that there will be, coming out of this, a kind of global cooperation, facilitation of research that can respond and that can, you know, address public benefit in a different way to the way that it had before?
Yeah, I completely agree, Hugh, and I think that's what I was hearing. You know, when I think it's a very good question, and I think that we're seeing a lot of collaboration between industry, academics, and various organisations, and between different companies in industry. So I really hope that that's what will happen. Yeah.
I'm just picking up questions fairly randomly from the list that I've got. There's one I think is interesting. I just wanted to explore a little bit more the question about skipping through the early stages of clinical trials. So whether it's the in vitro stage, the animal stage, and moving directly to human phases. One can understand the significance of this, but or why people might want to do that. But are we putting too much pressure on those healthy volunteers who we may be asking to take a greater risk than we would ordinarily?
I can speak to this, or Jeff, do you want to start perhaps?
Okay, sure. I mean, I'll say, of course, that's the very important question that we want to make sure is not the case. We don't want the answer to be yes to that question. There have been some very interesting interviews posted on Twitter and elsewhere in the last few days, because the first subjects in the US trial have just started to be enrolled. And so both the consent form and some interviews with the subjects have been posted. And I will say it's quite impressive that the individuals who have been interviewed, and so that's a selected population, understandably, seem fully aware that they're undertaking something that likely is more uncertain than it might be in other contexts. And they seem to understand the potential harms that could happen to them. It isn't sort of, well, I understand there's some risk, but I don't really know what it is. They seem very articulate about what those might be. And they seem sort of eyes wide open about the fact that they're doing something for the benefit of others during an unprecedented emergency time in our history. So that feels to me good about the way that they seem to appreciate it. That said, you know, sort of how far can we push that in the interest of expediency, and how much is too much to push onto consent, right? We can say, well, we'll just tell people what the risks are and let them decide for themselves. But there's a limit to what's acceptable risk. And I think that's what we have to make sure we don't, you know, we can walk up to, but not cross that line. I don't know what that line is, but I think that's, of course, the challenge.
Yeah. And I was just going to add, my understanding, I forgot to say at the beginning, I'm a physician and I used to work in vaccine research, although I'm not an expert particularly in that area. But my understanding is that the reasons for skipping some of those stages would be justified in that some of the types of vaccines, part of the vaccine called the platform has been used previously in similar vaccines, for example, for MERS. So there is an argument that it's not as risky to go in without doing all the animal work, and also that there's about 30 vaccines in development. And of course, that's a lot of preclinical work to do. And there is a shortage of non-human primates, which tend to be used for this kind of work. So in practical terms, if you're going to work on that many vaccines, it may not be possible. And the other, again, we're talking about sharing data as well. I think there's also been proposed that the data is shared between different companies if they do some preclinical work, and we can learn from that for another vaccine. And I've seen publicly available informed consent for one of the studies, and it clearly is explaining the risk. And as far as I'm aware, they have received you know, sort of people volunteering to take part in the study. So but yeah, it is a risk that's important to be aware of.
Can I pick up one more question and going into a completely different area now? This is about community engagement. And Beatriz, I know that this is something that you've talked about, are very concerned about, and with the report that the Nuffield Council published, a question came up about even if we all recognise the value of community engagement in working up research proposals, in their implementation, etc., how do we manage this in a situation that not only is so urgent, needs to be got together so rapidly, but also in a situation where we are, so many of us, in lockdown, and that kind of communicating people is going to be so difficult. Is community engagement still something that we can reasonably aspire to, and are there practical ways of going about it?
Sure. So this is a very important question, and how to do that in such a difficult situation. I guess what we're trying to make people think about is that there must be some way to engage communities, and it's probably not going to be in the level that we would have liked to see. So, say from the inception of a study, at the moment of designing a study, probably we won't be able to engage communities at this point for now, but for sure, as early as we can, to engage communities, to inform, as Jeff and Sue said, what are the risks involved in participating in a given trial. So what we're seeing people do is take advantage of the social mechanisms that exist already. So it may be patient groups that meet at a given health center, or people that do a certain kind of activity at a hospital. So people are being urged to build upon what exists already. So, and now that we're not all in lockdown, the good thing is that we have technology working for us. So of course there's social media and WhatsApp, for example, that's very widely used. So I know, for example, in Kenya, there is community engagement already ongoing, and they're using WhatsApp groups, and that's really, that really decentralizes information, at least. So again, it might be not the level of community engagement that we would like to see at this point, but if it is what's doable, then fair enough, and these alternatives should be praised. So there is community engagement going, even if
I think
hard times.
I'm going to have to wrap up in a moment. I think that the question about how this is going to play out across low and middle income countries is going to be really critical. I think we'd like to come back to that in another seminar, because that's a big question to open up here and now. Before I go, I'm going to invite those who are attending to complete a very short and quick poll, just to help inform our future seminars. But first, of our three panelists, if there's a word that you just want to leave us with, is there something that you feel we just either haven't touched on, or that is a critical thought for people to go away with? Beatriz.
I'll go for hope at this point. I think people are working in with a lot of distress, and perhaps having people who are dear to them in the hospital. So I'll just send around a message of hope, and we'll get past this as humankind.
Thank you. Sue?
I think collaboration. I think that's really important, that we all work together. So yeah, that's my message.
Yeah, Jeff?
I just want to reiterate what Beatriz said. There are 500 people on this webinar, and technology is in some way a great leveler to allow us to reach out to more people in more ways. And I've been really touched by the Italian children's effort to tell us it's all going to be okay. Andro tutto bene.
Thank you. Thank you. That's great. Listen, I want to thank all of you, the three of you, for giving us your time, especially when you've come from the other side of the world and you haven't even had your breakfast yet. I'm going to open the poll, and so ask everybody if they would to complete that. I'll just say one final thank you, and then once you've had a chance to run the poll, I'm going to close it down, and hopefully see you next time. We'll be back in a week or two. Thanks very much.
Thank you.
Thank you.
Well, I think we stay live for the moment whilst I'm going to let the poll run, and we're still here. I'm not quite sure what's the best way to do this. Can I end the meeting and leave the poll open? Can anyone tell me that? No? Okay. Then we're just going to have to look at each other for a minute whilst everybody completes the poll.
Okay.
Oh, I'll get my advisors to work on that for next time.
We're not allowed to do it. That's not fair. We just have to look at the questions.
I know. I tried to vote too.
We can see the results coming in.
Oh, can you?
Okay. Yeah. Oh, it's looking good. It's looking good so far.
Good.
Real time.
Well, so one of the questions, I mean, just to reflect, I mean, we went for 40 minutes here because it felt as though asking people to spend that much time looking at a screen, it started to become difficult. But did you feel we could have gone longer?
Yeah.
I think we could, right? Yeah. Maybe another 10 minutes.
Another one this week for the Science and Entertainment Exchange here in the US, which is the National Academy of Sciences outreach to the entertainment industry, which went for an hour and they wanted to keep going.
Right.
So it was very similar format, almost exactly
Yeah.
the same. Actually, we each spoke for 10 minutes and then they opened it for questions that were moderated by your equivalent.
I mean, my feeling is I'm just seeing the results coming in. We've got 75% saying it was just the right length, 20% saying it was too short. Nobody said it was too long. I think I would have liked to have picked up more of the questions.
Yeah.
Yeah, it would have been good. Maybe
That,
another 10
I think
minutes.
was unfortunate.
Yeah.
That was a good first effort.
So, okay, listen, I think we're getting them all in. I'm going to end the meeting now. Once again, thanks to you all. Been really great working with you. I'm sure we'll be in touch again.
Thanks.
Yeah.
Thank you,
all.
guys.
Thanks. Bye.
Pleasure, really. Stay well.